We'll now shift focus to the mechanics of the vaccine rollout itself. It's an understatement to say there's lots happening in this space. We can see our news bulletins full every single night. There's lots of information, and I have to say lots of misinformation that's floating around, and I know that's been challenging for all of us as well. So to bring you the absolute latest, and also to explain key components of the vaccine, we are very thrilled to welcome back Professor Ben Cowie from Victoria's Department of Health. Ben is a senior advisor to the COVID-19 immunisation program. Ben, a significant welcome and thank you from all of us, as a lot's been happening over the last week and since we last held our Vaccinating Victoria, our first briefing series. So perhaps if I hand over to you to begin with to give a kind of general update, and then we'll jump straight into questions. Thanks.
Thank you so much, Emma, for the opportunity to be here today. It's a great pleasure to be here and to discuss with all of you the vaccine program and hear your perspectives and advice. I will present an update briefly, and then we can get to the Q&A. But before I do want to acknowledge that I'm on the lands of the Wurundjeri people of the Kulin Nation, and acknowledge their elders past, present and emerging, and acknowledge the elders of the lands where I live, the Bunurong people, also of the Kulin Nation. So I would like to share my screen and then we'll get going. So hopefully that's presenting okay. So thanks for the opportunity, Emma, as I said, and colleagues. So we have spoken about the vaccination program previously. Just to reiterate, though, that there are three pillars for the program, and I'm sure that these are very close to the hearts of all the VCOS members and friends and colleagues that are present on the call today, and that these are fundamentally founded on principles of equity of access, both geographically but also in terms of the appropriateness of the vaccine program and at wherever people are accessing vaccination, that is done in the highest levels of safety and quality. And thirdly, that we maintain public trust and confidence. And as you mentioned at the start of just before when you were introducing me, Emma, public confidence has taken a hit in the last couple of weeks. We have to acknowledge that, and we have to find ways to relate the absolute evidence base and the accurate information at the same time as having a view to maintaining confidence of people in these vaccines, which remain very safe for the vast majority of people and also very effective and will protect Australians, as they are already doing overseas, from the devastation that COVID-19 has caused in so many countries and in so many health systems internationally. So this is a Commonwealth program. It's the Commonwealth government who have procured the vaccines. It's the Commonwealth who distributes the vaccines, both through their direct programs, such as in residential aged care and residential disability care, and also through the general practice network. But it is also the Commonwealth who distributes the vaccines to states and territories for use in our state-supported programs. So the Victorian government clearly has responsibility for commissioning and supporting additional vaccination clinics. And as was announced by the Health Minister, Minister Foley, yesterday, there's been an increase in access through the state program, which I'll come back to later in my update, but also ensuring that we have our own state-based policy and safety mechanisms and training in place to ensure that irrespective of where a Victorian is vaccinated, that we're doing that in the best and safest way we possibly can, and following the best public health advice that's available to us. But ultimately, it's the people doing the vaccination who are the critical element here, along with the community members coming forward to getting vaccinated. Because it's the vaccine centres, whether it's a hospital, whether it's a high volume or a high throughput site, right down to a mobile team vaccinating some people in a priority community, that has to be done in the safest and highest quality way we can ensure. So we're currently working our way through phase 1A and 1B of the Commonwealth's vaccine rollout nationally. And these groups are certainly nationally agreed. Here in Victoria, we have added some groups to the to be vaccinated alongside 1B, and that really reflects Victoria's experience of the second wave of COVID-19 here in Victoria, and ensuring that we have high levels of coverage of some of those groups who we know from tragic experience last year are at greater risk of acquiring COVID-19. I'm thinking particularly about, for instance, people living in high density public housing and some other priority groups that we've identified. So in relation to the issues that we were just mentioning about confidence in the vaccination program, and particularly around the AstraZeneca vaccine, we have seen a reduction in the number of people coming forward to be vaccinated through our state program. And there's also been a relatively smaller downturn in the fantastic work being done by our GPs in Victoria. These numbers, so just over 164,000 doses delivered up until yesterday in the state program, which is roughly matched by the number of vaccines that have been given by Victorian GPs in recent weeks. And we're continuing to work really closely with our GPs because they're doing a fantastic job in what is quite a difficult environment for them to be vaccinating Victorians, but we're really grateful for the work they're doing. So one of the important aspects of the AstraZeneca vaccine is that it doesn't need to be kept at such cold temperatures for long-term storage as does the Pfizer vaccine. And this really is why it's the vaccine that's been rolled out in general practice, but it also gives us the opportunity to have more, I guess, diverse delivery models for vaccination. So not just limited to our hospital immunisation hubs, nor our high volume vaccine centres, but really opens up other opportunities such as mobile teams being able to deliver vaccine to priority communities close to where they live. Also through the fantastic work of community health centres, who were so important to serving the needs of so many Victorians last year who either were affected by or were at higher risk of COVID-19. And so we're really excited about working with our community health partners in delivery of vaccination, again, through their networks. I guess the other really important structural part of how we're trying to coordinate vaccination closer to local communities is that these hospital hubs that were the initial sites that Pfizer vaccine was made available through, they're also aligned with our local public health units in Victoria, which are going to be part of our public health infrastructure going forward. And I'm excited about the potential for local public health units to really have that connection to their local communities in a way that a whole of state health department level really can't. And I'm really also hopeful that by supporting our local public health units or LPHUs to take on this regional coordination approach for vaccination against COVID in their catchments, that will help build those connections with local community, with local health providers, with community organisations, so that this can become part of really driving forward that public health reform in Victoria. So our high volume or Vic Icon centres are a part of what we're trying to offer. Now, these are specifically offering AstraZeneca vaccine at this point in time. And we now have 6 up and running, the initial 2 at the Austin or the Heidelberg Repatriation Hospital and at Sunshine Hospital, joined by the Melbourne Convention and Exhibition Centre and South Wharf, run by the Royal Melbourne, the Royal Exhibition Building in Carlton, run by St Vincent's, and the old Ford factory in Geelong, run by Barwon Health, alongside the Mercure Ballarat, organised by Ballarat Health. And we also will be having the Melbourne Showgrounds joining the fold in the next couple of weeks. The reason I've highlighted the convention centre, the exhibition building, and the Ford factory is because those three were announced yesterday by Minister Foley as opening their doors to all eligible 1A and 1B Victorians from this Wednesday. So I'm really quite excited about that for a variety of reasons. But essentially, it's starting to really build that open access principle. We anticipate that this will largely be used in the first instance by Victorians aged 70 years and over, one of the eligible 1B groups. Look, it is still the case that the best place to get health advice, including advice about COVID-19 vaccination, is with people's GPs. And if people have access to being vaccinated by their GP, they should really take that opportunity. The high throughput centres are really about us adding options for people and trying to get as many eligible Victorians vaccinated against COVID-19 as quickly as we can, because we want to have high levels of immunity in the community going into winter. So that's the mission, if you like, of opening up these high volume vaccination centres or Vic Icon centres to all 1A and 1B populations, including people aged under 50. But I'll come back to that point following the ATAGI advice in a moment. So how can people book into these sites? Well, on this slide, you can see the hotline that can be called to book in an appointment. And you can also visit the website at coronavirus.vic.gov.au/vaccine. These slides go into a bit of detail, but in summary, it's clearly been a very significant couple of weeks in the vaccination space in Australia and indeed internationally. I'm thinking particularly about the evidence of an association of the AstraZeneca vaccine with a serious but very rare adverse effect or side effect involving clotting, particularly in people aged under 50 years. And as a result of a review of the evidence, ATAGI, the Australian Technical Advisory Group on Immunisation, have advised that the Pfizer vaccine is preferred in adults aged under 50 years. So AstraZeneca can still be given under 50 years, but that needs to be done in consultation with the person seeking vaccination and with appropriate informed consent and consideration of the risks and benefits. But this does introduce significant complexities to the vaccination program. So it is a very rare side effect. It is roughly 1 in every 200,000 people vaccinated. So it's of a similar order of magnitude to being struck by lightning in a given year, slightly more frequent, but it is very rare. However, it is serious, and it is something that obviously we all need to take seriously. So ATAGI's age-based recommendations really are trying to strike the balance between vaccination in a population where fortunately we don't have active ongoing COVID transmission, but still seeking to protect the community, because if transmission of COVID does commence again, the risks of serious outcomes of COVID-19 are vastly greater than is any risk of this clotting disorder. And that's the balance we're trying to strike. So I note that I'm getting a little bit over time. I won't go into too much detail, but essentially for people over the age of 50, it's still recommended that they proceed with AstraZeneca vaccination as previously. For people under the age of 50, if they've already had their first dose of AstraZeneca vaccine, it's safe to go ahead and get the second dose. If someone has not yet had any COVID-19 vaccination, Pfizer is now preferred, but because of the limited supply of Pfizer in the community, this will need a discussion between each individual and a decision about how they go forward in relation to vaccination, waiting for Pfizer or receiving AstraZeneca. So there are some challenges here, and I think that's the central one at the moment, this dialogue around Pfizer and AstraZeneca. That's my last slide, so I'll stop there. And once again, thanks for the opportunity to be here and to talk with you today.
Thank you so much, Ben. We've got lots of questions coming through. I might just throw to one because it relates to sort of your last point. And it's from Julie, who said that her husband had quite severe side effects from the AstraZeneca vaccination, the first dose. Is he likely to experience the same in respect to the second?
So great question. And look, let me start by saying the best person to ask for personal health advice is your doctor or your healthcare provider. And really going and having a chat with your GP is the best idea here. It really depends on the nature of the side effects that were experienced. There are, from any vaccine, expected adverse events, things like fatigue, headache, local pain in the site of the vaccination. That's the only one I got after my AstraZeneca vaccine. And sometimes fevers and chills, and they can be quite significant. We know that around 20% of people following AstraZeneca vaccine after the first dose found that it either interfered with their work the next day or with their activities, their usual daily activities. So they can be significant, but they are expected. What is different about the AstraZeneca vaccine is those sort of side effects that happen usually in the 2 or 3 days after vaccination are significantly less after the second dose. And that's the opposite for the Pfizer vaccine, where people have more side effects after their second dose. It's interesting. But if it's that sort of side effect, expected side effects following immunisation, then on average, they're better the second time round.
Thank you. And I've got another question from Bruce in terms of, if I take my elderly dad to one of the mass vaccination centres, can I stay with him the whole way, or will I need to leave him at some point in the process?
People can have support people to attend the vaccination sites. That's absolutely fine.
Fantastic. Thank you. I think you've answered this question actually in your presentation, but I'll just touch on it because it was one of the questions put through earlier. In terms of, if I work at a disability service and I'm in category 1A, but I still don't have my vaccine yet, what should I do?
So it really does come down to your age at this point in time. So Minister Foley yesterday announced that our high throughput centres, those 3 that I've mentioned, the exhibition building, the convention centre, and the Ford factory, and they will be joined by more in coming days, that any eligible person can receive AstraZeneca there. And that includes people who, up until now, had been really the focus of the Commonwealth vaccination program, including aged care and disability care workers in residential settings. So we would welcome anyone who's over the age of 50, or if you're under the age of 50 and are happy to consider getting AstraZeneca following discussion of the risks and benefits, we would welcome you at our high throughput sites. For people under the age of 50 who are choosing to receive Pfizer vaccine, that is now significantly more complicated. We will be providing Pfizer through our hospital immunisation hubs for people aged under 50 years. But that is going to take longer because of the significant supply constraints with Pfizer vaccine. And we'll be providing more information on how particularly 1A and 1B workers can access Pfizer through those hubs in the coming days.
Thanks, Ben. And we've had quite a few questions coming through both before today and also with today as well, in terms of, I guess, the message to people over 50. And I think there's been quite a few people coming and saying, look, I'm 51 or 52. You know, got this kind of magic threshold of 50. They're still worried about the AstraZeneca vaccine. What's your message there?
So there's a few layers on which I would discuss that. Look, I totally understand people's concerns, and I totally get that people have questions. That's really healthy. And I think it's really good that people are considering the risks and benefits at their individual level. I'm not quite 50. I'm not far shy of it, but I'm not quite 50. And I got the AstraZeneca vaccine. And I think a significant number of people under the age of 50 are continuing to choose to receive AstraZeneca vaccine. That magic cutoff, you're absolutely right. It's a line in the sand. It's not based on there's risk below 50 and zero risk after 50. Whenever these sort of thresholds are determined, it's about the balance of risk and benefit. We know that the risk of serious adverse outcomes of COVID-19 increases with each decade in age, and it's not, again, it's not a hard cutoff. It increases with every increasing decade of age. It seems at this stage that the risks of this very rare but serious side effect are particularly under the age of 50. And all cases in Australia, for instance, that have been potentially associated with AstraZeneca vaccine have been aged under 50 years. So it really is about making that call. Can I make one other point? This situation is different in Australia than the vast majority of countries because we're not in the middle of a wave of the pandemic, which is resulting in hundreds, thousands of deaths every day. And a lot of the other countries are. And so it makes this risk-benefit equation more complicated, there's no question. But if we were to be in the sort of situation like Victoria was last year in the second wave, and we all hope, obviously, and we're all going to work so hard to make sure that doesn't happen. But if we had the same level of transmission in the community, the benefit of vaccination would exceed the risk of this clotting problem all the way down to people aged 18 and over. So it really won't take much for that risk benefit to be very different. And that's what we're facing here, is trying to balance the rare but serious risk of this disorder versus the risk to the community of having low levels of immunity and therefore a greater chance of ongoing COVID transmission as we head into winter. It's a difficult thing to do on a public health level, and it's a difficult thing to do on an individual choice level. But that's the guidance we've got, and that's what we're trying to put into place.
Thank you. I think this next question might go to one in terms of you're saying, consult your GP, but we've had a question come in around saying, look, if you're over 50, if you've got a history of blood clots and you're on blood thinners, is the AstraZeneca vaccine safe?
So the advice, again, from ATAGI is that really the only contraindications to the AstraZeneca vaccine over the age of 50, apart from a history of anaphylaxis or severe allergic reaction to AstraZeneca vaccine or to one of the ingredients in it, if we're thinking about this syndrome, the contraindications or the people who should not receive AstraZeneca are firstly people with a history of that specific type of clotting in the brain. So cerebral venous sinus thrombosis, which is exceedingly rare, or people with a rare side effect from a blood thinning agent called heparin, which causes the platelet count to drop very profoundly. It's called HITS, or heparin-induced thrombocytopenia, HITS. And those are the groups who ATAGI are recommending not receive AstraZeneca. So yes, indeed, please have a chat with your GP, but at this point in time, other forms of clotting or being on an anticoagulant drug are not contraindications to AstraZeneca.
Thank you. That's really helpful. I've had another question. So I'll just go back to the groups that you had at the beginning in terms of 1A, 1B, etc. A question about what group do family violence, refuge and support workers fall under?
So I might have to take that one on notice. So certainly there's a range of support groups that have been put forward in the Commonwealth's sort of guidance, and certainly people who provide care to individuals who are in the 1A or 1B categories are included. But I might come back to you with that specific example so we can give you an accurate response if that's okay.
That's fantastic. Thank you. In terms of another question here around saying, my client doesn't have a regular GP that they deal with, in terms of looking at other options for GPs, I'm assuming going from your earlier slides as well, that looks at areas such as community health, etc. But would you mind touching on that a little more?
Yeah, for sure. So certainly, as we've said, regular GP, or if you don't have a regular GP, another GP who you can consult, community health centre, any sort. If you're a patient of a hospital outpatient service, and you've got an ongoing relationship with a health service, these are all fantastic sources of information. Ideally, it's someone who knows you and who knows your health and who knows your situation. But if that's not the case, and if you can't see another GP or attend your local community health centre, we certainly have a lot of trained immunisers. And for instance, at our high throughput centres, we've got both expert nurses and doctors available to talk to people. The idea of those high volume centres is really, as the name suggests, to be able to give access to as many people as possible. But if you have no other obvious route of access to vaccination, we want to support you. And therefore, attending those sites, you can discuss your own individual needs with a nurse or a doctor.
Thank you. In terms of the vaccination plans, I guess this is a specific question around the vaccination plans and approaches for people who are homeless, perhaps street-based, community members affected by alcohol and drugs or mental illness and trauma. Are you able to touch a little bit more on the sort of the processes that have been put in place for people in those situations?
So look, absolutely. And I think, as I said at the start of my presentation, Emma, equity of access is a fundamental principle that we're seeking to enshrine in the vaccination program. So in part, that involves ongoing partnership with groups such as Hurrah and other sort of structures that have been set up to address the needs of people with unstable housing or uncertain housing throughout the course of the COVID pandemic. And continuing to ensure that those groups who have vulnerable accommodation situations are absolutely a target of our vaccination program. So obviously the high throughput centres, but our partnership with community health centres and particularly around mobile outreach, all of the local public health units will have mobile outreach capacity as part of their offering as well. So this is not just something that's a central Melbourne issue. It is something that we can ensure that as we identify priority groups in different areas that have lower degrees of access to existing vaccination options, that we can try and tailor that to meet their needs. I think the one difficulty there that has been introduced since the ATAGI guidance is the need to offer Pfizer vaccine as the preferred vaccine to those aged under 50 years. And with the difficulties that the Pfizer vaccine brings in terms of storage and distribution, that's going to take some more work thinking about how that works with mobile offerings. It's not impossible by any means, but it's going to take a bit more programmatic work to ensure that we can do that. But absolutely, and like the C19 consortium who have already been up and running and vaccinating through those health centres are certainly looking at mobile options and particularly thinking about vulnerable populations.
Thanks, Ben. That's great. We've got a question from Gina around saying, given the vaccine doesn't stop transmission, should I continue avoiding visiting my immune suppressed mum even once she's vaccinated? Because, I just don't want her to get the disease.
Yeah. So, look, while we're still building the evidence base here, it is clear that these vaccines, both Pfizer and AstraZeneca, do prevent transmission to some degree. We've got increasing evidence, for instance, from healthcare worker surveillance in the United Kingdom, that even asymptomatic infections, when people are being swabbed every week regularly to see if they've got COVID, that is significantly reduced in vaccinated individuals, even after the first dose, even when they have no symptoms. So it does block infection. And we also know that a vaccinated person, even if they are infected in the short period after their first dose, from about 12 days onwards, they have less amount of viral shedding compared to someone who wasn't vaccinated. So their infectiousness is less. So these vaccines do block transmission to a degree, and they do prevent ongoing transmission. So that's really important. The other point I'd like to make here is that if someone is either a paid or voluntary carer for a person who's eligible for vaccination, then they too are eligible for vaccination. And so that additional element of protection, if they are a carer as defined under the Commonwealth guidelines, then they too could be vaccinated, which adds to the protection of that vulnerable individual.
And then just building from that as well, because that actually segues nicely into another question I had around volunteers who were sometimes working face-to-face with people. Do they fit into that same category as well. I know your definition around carers. Can you explain what happens in terms of volunteers who are working with people who are in vulnerable circumstances?
Yes, so we certainly can, and I can again provide some more information on that. There's some Commonwealth definitions that we can post through, so people have got the actual written information in front of them, because there is some differences depending on the type of care and voluntary or paid that is delivered and to whom. So we can make sure that those resources are available, because the last thing I want to do is to mislead anyone. So we'll provide links to that.
Fantastic. In terms of another question, we run a supported accommodation facility. Are we able to take a group of our clients to a mass vaccination centre, and is this advisable?
So it really comes down to an individual decision. I guess the high throughput centres or the high volume centres are really geared around people who ideally don't have complicated needs, are quite mobile, able to provide informed consent for themselves, obviously, when they come to the site, and are eligible, obviously, eligible for vaccination at the time. I think that model would probably be tested by a group of people attending, particularly if they've got differing needs, differing ages, also differing abilities to provide informed consent on site. So what I would recommend there is, if there's a group, and clearly the Commonwealth is still primarily responsible for delivery of vaccination in supported accommodation in residential disability settings. The Victorian government is continuing to work with the Commonwealth on trying to improve the implementation for both residential aged care workers and disability workers and residents in Victoria. So we're hoping that we'll have some more information available in the coming days on that. My gut feeling would be that whilst I totally understand and greatly appreciate the enthusiasm of people to get their clients vaccinated, just my gut feeling is that that would test the ability of a high throughput centre to provide adequate service to those individuals. Perhaps something we could discuss a little bit further before that step was taken.
Yes, and it kind of, again, this builds on to just another question, which I'll just type as well, in terms of from NDS, National Disability Services Victoria, which is around how can disability service providers book for an outreach team to attend and deliver vaccination, with individuals at a day centre, employment centre, et cetera, who'd find it overwhelming to attend one of the larger vaccine sites. Just wanted to touch on that because it seemed to sort of segue with a previous question as well.
Yeah. Look, absolutely. And to reiterate that certainly for the residential setting, that's still the Commonwealth running that, who has responsibility for that centrally. We understand that there's been, and I think the Commonwealth have also mentioned that they would like to see that happening faster than it has been. We understand there's some frustrations amongst residents and those caring for them around the pace of the rollout, particularly in the residential disability setting. And I note that we're not just talking about residential services here. We're talking about a broader offering, and you've cited the day settings, day centres, etc. I guess, yes, absolutely. The hubs have a regional coordination role and can help in those discussions around access for those groups in 1A and 1B. Noting that, again, there is issues around Pfizer access and being able to ensure that Pfizer vaccines are available by choice for those under the age of 50. The other thing that I would like to suggest is that, and this is certainly the Commonwealth have put this forward for some groups in their sort of area of responsibility, is partnering with local general practice and finding out what options are available through those local practices. I think people who have got established healthcare relationships with their GPs, that gets around some of the concern and understandable hesitation at attending a big hospital or a site that you've never been to before. And so I think that partnership with local general practice is something that I would really found all of these conversations in. But if for whatever reason that's not a possibility, then yes, our hubs do have that regional coordinating function and can discuss other options as time goes by.
Thank you. And again, probably leading on from your previous question around the Pfizer vaccine, we've had Lisa saying we're looking for a clinic that provides the Pfizer vaccine. Is there an easy way to do this, or will it involve them sort of phoning around?
Yeah, so for noting, really, it's only the hospital immunisation hubs who have Pfizer vaccine at this point in time. There is outreach from those to, for instance, other health services in Victoria to vaccinate, for example, 1A healthcare workers, emergency departments, COVID wards, etc., and to sites like hotel quarantine environments, to the airport, etc. Really, since the target advice was issued 11 days ago, we're doing a lot of work with our hubs and our local public health unit partners to think about how we can facilitate access to Pfizer for eligible people aged under 50 years. We will have more information available on that in coming days. But at this point in time, I would basically advise against just ringing around different clinics, because essentially no general practices have access to Pfizer. And it's really only those 9 hubs in Victoria that are central locations for Pfizer to be rolled out from. So I think that would lead to a certain degree of frustration on the people making the calls when they ring around and can't find anywhere other than the big hospitals. So we will have more information available in coming days, and we get that this is a real priority.
And thank you, because I know a number of GPs have also been in contact saying they're just inundated with the phones ringing off the hook as well. So I think it's really helpful to have that information. We've had another question around clarifying sort of specific risks of the vaccine for women, maybe looking, for example, at women who might be on the pill or might be breastfeeding or IVF, those sorts of things as well.
Yeah. So I'll answer that in 2 parts, if that's okay, Emma. The first is about guidance around pregnancy, breastfeeding in general, and then secondarily about the particular clotting concerns there. So firstly, both the vaccines have been advised as being safe in the setting of breastfeeding and in people who are either planning to or trying to get pregnant. Noting that now, for people under the age of 50, Pfizer is preferred. That adds that other dimension there, because clearly there's that age-based criterion which applies to women who are breastfeeding and who are planning or trying to get pregnant. For women who are currently pregnant, the advice is currently that routine or vaccination is not routinely recommended. That's not because we have evidence or concerns about specific safety issues in pregnancy. It's we just don't have enough data to be able to say that it is categorically safe to do so. There has been a lot of pregnant women vaccinated overseas in countries where the pandemic is really very causing a serious health problem, clearly. And we're waiting for further information on those cases so that we can provide more evidence-based advice. So in summary, for pregnant women, not recommended routinely to receive any COVID vaccination. And for women who are breastfeeding or who are planning to become pregnant or trying to get pregnant, it's okay to get vaccinated and it's considered safe, but noting the age preference for Pfizer for those aged under 50 years. In terms of the specific clotting issue, again, sort of similar to the question before about someone who's had previous, for instance, deep venous thrombosis in the leg or is on warfarin or another anticoagulant for whatever reason, no specific evidence of increased risk in the groups that you mentioned of this very specific type of clotting. It does appear to be more common in females overseas, but it's certainly seen in males as well. And similarly, whilst it is more common, significantly more common in people aged under 50 years, and it has been exclusively people under 50 in Australia, that's not the case overseas. And there have been older individuals who have experienced this very rare disorder. I do want to just come back again. It's understandable that people have such a degree of concern and focus on this issue. Can I just reiterate, whilst it is a serious side effect, it is incredibly rare. We are talking about 1 in every 200,000 people vaccinated on average. Whereas, the risk of tragically losing one's life on Australia's roads is about 10 times that in any given year. It's about 1 in 25,000. So it is really important that we understand these risks and we address them and we're open about them. But I think for a lot of people, big numbers like 1 in 200,000 is hard to relate to, but maybe thinking about that, putting in perspective of, for instance, the number of people who lost their lives here in Victoria from COVID last year, and thinking that if we had that sort of transmission in the community again, the risk of vaccine is much, much, much less than the risk of even getting really sick from COVID-19.
Thank you. Another question here as well, in terms of if I'm booked in for a vaccine and I become sick, should I cancel my appointment?
Yeah, it's a good question. So essentially, the contraindications to any vaccine, not just COVID, but any vaccine, if someone's got a fever, so a suspected infection, and have a fever, they shouldn't come forward to get vaccinated. Someone who's got acute medical issue, of course, they should also not come forward and get vaccinated. If you've got a chronic background health issue that is just grumbling along, that is not associated with any particular acute illness, then it's okay to come and get vaccinated. But really, if you've got a fever, or I should really say, if you've got symptoms that could be consistent with COVID, so fever or cough or respiratory symptoms, please don't come and get vaccinated. You should isolate and get tested. But for other illnesses, it's as I've said previously.
Thank you. And in terms of, if you're attending a vaccination centre, do individuals have to, because actually to a question, do individuals have to provide proof of underlying conditions if they're under 70, or is their sort of word considered okay?
No, they do actually, and that's the case for anywhere. So if they're attending their own GP, then the GP's medical records suffice in terms of that evidence. But if they're attending somewhere else, they will need either, for instance, the download or the transcript from their My Health record, or they might use a letter from their regular GP saying what their medical condition is. Because it's not any medical condition. There's a list on the Commonwealth's eligibility checker of which medical conditions are eligible under 1B for vaccination. If someone can honestly not provide either, for instance, a discharge summary from a hospital, a letter from their GP, a download from their My Health record, or any other documentary evidence, they can fill out an attestation form, which is available on the Commonwealth eligibility checker, where they basically attest that they have a medical condition that makes them eligible. So again, the eligibility checker, which Mel has just very helpfully posted in the chat. I see Mel's been working furiously in the background, answering all the questions that I haven't been able to. So the eligibility checker there is the place to go.
Thank you. And just a shout out to Mel as well. You're doing an amazing job, Mel, as I keep seeing it flash across the screen. So if someone, a question here around, so if someone tested positive for COVID last year, do they still need the vaccine?
Yes, they do. And in fact, we know that the immunity from COVID-19 is neither absolute nor does it last forever. We've seen second waves of infections amongst people who have previously been confirmed to have COVID-19 occurring overseas. So yes, please do get vaccinated against COVID-19, even if you've got documented evidence of having had it before.
Thank you. If someone's very against vaccines, should I try to reason with them or argue the facts with them, or is this not a very effective technique?
Yeah, look, that's a really interesting question. And it really comes down to, well, a range of factors, I think. We know that on average, and look, I think a lot of people are more concerned now than they were, say, a couple of weeks ago, and that's understandable. We understand that. The first thing is, but prior to this happening, it was pretty consistent that around 70% of the population were intending to be vaccinated. Around 20% were uncertain, and those two varied, okay? So the uncertain people might go up, and the people who are intending to get vaccinated went down, and they varied. The people who really didn't vary was those who were not intending to get vaccinated. They were stuck at around 10% and didn't really budge. We believe that there are some people who, for reasons of their own, irrespective of much else, are committed to not get vaccinated. And I guess where we're focusing a lot of our energy and attention is on that 20% of people who are uncertain. So if you feel comfortable talking to someone, I think the strategy that I use when I'm discussing this with people who are uncertain is, first of all, to ask questions. is to ask why they're not intending to be vaccinated, or ask what their concerns are, and to explore where they come from. And if it's something that I feel is amenable to discussion, I never try and tell someone that they're wrong, of course, and nor do I say, well, the facts and figures say this, so therefore, that you're not right. That's not the way to approach it at all. I think having a discussion, finding out what their perspectives are, what their sources of information have been, and I think one other question to ask is, have they had other vaccinations? And if it's someone who's happy to or has had other vaccines who are particularly concerned about the COVID vaccine, that opens a point of discussion that can be explored. But honestly, this is a universal but a voluntary vaccination program. No one has to get vaccinated. And by the same token, no one, I think, should be forced to have the sense that their choice is being undermined, but providing information. And I think providing not just facts and figures, but narratives is going to be really important. Why people are choosing to be vaccinated, why they're choosing it, what it means for them, how they feel about being vaccinated. That's just as important evidence as numbers, statistics, and facts.
Yeah, thank you. And then questions just come through, which I think is kind of it's different but related. So I've heard this from a few places in terms of attitudes and feelings of young people as well. And we've had a question, I'll just read it out verbatim. Young people are losing trust and confidence in the vaccine program, as they will largely be vaccinated in the last phase of the rollout and are being recommended a vaccine that's hard to access. How should youth workers be communicating with young people about this?
Yeah, it's a really, really good question. And again, can I just put a personal perspective? If I was to have the choice again, so I had the choice to get AstraZeneca or Pfizer, and I chose AstraZeneca for a variety of reasons. For me personally, and I'm not saying this should be anyone else's decision making, but for me personally, the risk and benefit was so much in favor. And by getting AstraZeneca, that means that there's another dose of Pfizer available for a young person as we go forward. So I think that is also part of my own personal way of looking at this, that the more people who get AstraZeneca over the age of 50, the more doses of Pfizer, which are very constrained, become available for people under the age of 50 who are eligible, whether they are 1A or 1B or as we go forward. So that's the first, and that's just my own personal viewpoint. I'm not assuming that should be anyone else's. I think for young people, again, it's perhaps a little bit alienating to hear these conversations about who's going to get what right now when they see their time horizon as being quite distant. And I guess for young people who are eligible, so whether they're working in a 1A or 1B cohort, or whether they have a medical condition, for instance, or a disability that makes them eligible for vaccination, we really need to find ways of giving them choice. And if that's Pfizer, then we need to get it to them, and we need to find ways to facilitate that. For young people to get, despite the fact that most young people will have milder COVID-19 and on average will not get seriously ill with COVID-19, there are exceptions to that. And I looked after some in hospital last year. And some people do get significantly unwell, even quite young people with COVID-19. So I don't know that I've answered the question. I think the principles are, we need to follow the eligibility criteria because they've been established to guide us from a public health and clinical perspective. And so they're trying to balance the risks versus the constrained supply that we're facing. But I think finally that ultimate element of trying to use as much AstraZeneca as we can to protect those for whom either vaccine is preferred, and thinking particularly people age 50 and over, so that we have as much Pfizer to use as possible for people under 50 for whom it is preferred. And I think that's a principle that is going to be one that is occupying a lot of not just vaccine program people, but in fact the general community as these conversations continue.
Yeah, and it's a good point. I have to say, one I haven't heard before that makes you think about it in a bit of a, made me think about it anyway, in a bit of a different way as well. So In terms of looking also about being able to report adverse effects, I've had a couple of questions come through around saying, well, how can the general community report adverse effects other than talking with their GP? And I understand from another question that's come through, there's sort of somewhere in the US that I'm not familiar with that you can kind of report adverse effects. Just interested for, in your observations around that.
Sure. So there are a range of ways, and we want people to have a number of different routes to inform about this. I mean, I think one of the concerns about the vaccines in general is that it would all be conducted in secret and things would be hushed up. Well, if there's one thing that we can take from the conversations that have been happening in the media over the last couple of weeks, it's clearly that this is being transacted very openly and that these reports are made available to the public, both by the TGA and discussed by ATAGI, and there's no question, I hope, in anyone's minds anymore that anything's being hidden, because if you're going to hide something, we wouldn't be having these conversations right now. And I think that's important as we sort of reassure people about the safety mechanisms that are in place. Secondly, for people who are vaccinated through our state services that are using the information system called CVMS, they get sent texts after their vaccination. I think it's day 3 and day 8, and then further down the track, to monitor what their symptoms are and to check on how they're going. So we have that passive sort of information feed coming in from that route as well. Yes, any medically attended adverse event needs to be reported to SafeVic here in Victoria, which is a surveillance mechanism and safety monitoring for all vaccinations. And in addition, people can report their own side effects if they didn't see a doctor, either through SafeVic or to the TGA directly. So there's a route of different ways people can notify. But again, if you're feeling side effects and you're concerned about them, I would strongly recommend you make an appointment and catch up with your GP.
Thanks, Ben. And I think in closing as well, it was a nice personal question for you, which you don't need to answer, but I think it shows the appreciation for the work you and your public health colleagues are doing, which is actually a question for Ben. When do you get a holiday and where will you be going? I think we are all in awe of you and the broader public health team in terms of, leading Victoria and leading the nation through this pandemic. The work that you're doing is just phenomenal. So I think it's there's a couple of questions coming through actually saying, we think you've earned your holiday about 1 million times over, and hopefully you get a chance for a break and a bit of time out as well. And I think that probably reflects the way that we're all feeling when, can I say, in time, I know that you are back to back probably every day and just about all night in terms of the work you're doing, and yet you're so generous in terms of being able to spend your time with us today and make sure that everyone is informed and knowledgeable as possible. So I just want to pass on my sincere thank you to you and the team that you're working with. You're fantastic to work with. You're always incredibly generous in your time, as you've been again today. And I know also how much it's appreciated, because you just give it, the answers are really, you're really straight in giving the answers of going, look, I don't know, these things are changing. This is what we're going to come back and see. So it's very, very much appreciated. So I just wanted to pass on my sincere thanks and the sincere thanks of everyone who's online, because I've had lots of comments come in along those lines as well. I want to say a huge thank you. Thanks, Ben. Sorry, I'm not sure if there's anything you wanted to say as well.
No, I just I'm really touched by that. Thank you.
Yeah, it's as I said, a number of questions have come in along those lines, and it's very I think we're in awe of the work that you do, and you kind of look at, it's interesting watching our public health professionals become the new rock stars, really, in terms of looking at leading the world and literally saving lives. So it's phenomenal. Thank you.
Thank you. As long as you're not talking about the fact I need a haircut, Emma, but thank you.
No, but you could take that as a compliment anyway.
Thank you so much.
Thank you. So a huge thank you to all of our presenters today. As I just mentioned, having Ben back online with us, and Mel also from Department of Health, looking at every question that's coming through and, providing as much information as possible. Also to Melissa and to Boca from law firm Justitia, and to our Auslan interpreters as well. We've got Julia and Janaea who are online and have been online through the whole presentation. So a huge shout out to both of you. We really appreciate it. And of course, to everyone who has submitted questions, to the public health team, you're phenomenal. You always are. We love working with you, and you've just been brilliant to work with. And the VCOS team, everyone behind the scenes who works to make these events happen. We have hundreds of people register for everyone, and we also know they're watched regularly afterwards. As we mentioned earlier, please feel free to share the webinar from today as far and wide as you want. We want appropriate, accurate information getting out as far as we possibly can. We know not everyone's able to jump online at the time, so feel free to share it. We will email it to you. You can share it after that as well. And remember that everything will be fully captioned. It's really important we make sure that all information can go to all members of our community. We will be running a third event in the Vaccinating Victoria briefing series. So do keep an eye out for that. And if you have, any particular topics or series of sort of questions that you're particularly interested in, do let us know. We want to tailor these to the things that you want to know more about. So feel free to reach out, let us know. We'd really welcome and appreciate any feedback that you've got. So I'd just like to finish by thanking everyone again and thanking all of you for joining us. Have a wonderful afternoon. Thanks, everyone.